plan of this presentation will be to have an introduction, ETA pathogenesis and pathology, evolution, surgical management of early epithelial ovarian cancer, surgical management of advanced epithelial ovarian cancer, laparoscopic surgical staging and HIPEC, palliative surgery, and a conclusion. To introduction, 70 to 75% of epithelial ovarian cancer are diagnosed with peritoneal carcinomatosis, ascites, and sometimes pleural effusion. The risk of a woman developing ovarian cancer is 1 in 70, and early epithelial ovarian cancer, the procedure done is called staging or laparotomy. And in advanced epithelial ovarian cancer, the procedure done is cytoreductive surgery. The 5-year survival for early ovarian cancer is more than 90%, and that of advanced ovarian cancer is approximately 46%. What are the risk factors for ovarian cancer? The median age of presentation is 60 to 64 years, and it gradually increases as the age progresses. And a family history of mutations like BRCA1 and BRCA2 increases the risk of ovarian cancer by about 60% in BRCA1 and 30% in BRCA2. And Lynch syndrome, there is 2% increased risk, especially of endometrioid or clear cell carcinoma. Increased risk due to the increased number of ovulatory cycles and polycystic ovarian disease and endometriosis. And in endometriosis, there is a 3.05 relative risk of clear cell carcinoma. Other malignancies include endometrioid carcinoma, low-grade serous carcinoma, and smoking has a weak association. Coming to the protective factors, there are certain strong protective factors like salpingo-oophorectomy due to the interruption of ovarian blood supply to an extent, high parity, oral contraceptive pill use, protection up to 10 to 12% at 1 year and 50% at 5 years, basically due to the decreased ovulatory cycles in all these. And weak protective factors include hysterectomy and tubal ligation, incomplete pregnancy, and lactation. Coming to the hypothesis, how does an ovarian cancer develop? There is a theory called incessant ovulation theory. Early menarche and late menopause leads to more ovulatory cycles and more mutations with the repair of the ovarian surface epithelium predisposed to malignancy. And next hypothesis is gonadotropin hypothesis, LH or deposit directly involved. Coming to the pathology, ovarian cancers are composed of epithelial tumors, sex-cut stromal tumors, and malignant germ cell tumors of the ovary, as well as non-specific tumors of the ovary and metastatic cancers to the ovary. And in the pathology, there are 3 main types of ovarian tumors with 3 tissue of origin. Epithelial tumors from the ceromic epithelium, malignant germ cell tumors from the primordial germ cells or oocytes, and the sex-cut stromal tumors derived from the steroid-producing cells, responsible for nourishing the germ cells and oocytes. The epithelial ovarian tumors being the most common, approximately 90% of ovarian cancers, serous cystadenocarcinoma, mucinous cystadenocarcinoma, endometrioid carcinoma, undifferentiated carcinoma, clear cell carcinoma, and benign and borderline malignant counterparts of the first 3 tumor types. So how does this ovarian tumor spread? First, by transcelomic spread, that is the exfoliation of cells into the peritoneal cavity. And subsequently by the lymphatics, especially in advanced disease, to the pelvic and the parietic lymph nodes, and hematogenous dissemination to the parenchyma of the lung and liver or cow. What are the clinical features? Usually the patients present with vague and non-specific symptoms, abdominal discomfort, distension or mass or bloating, vaginal bleeding and urinary symptoms, weight change, loss of appetite, and breathlessness due to pleural effusion. The signs include ascites, a pelvic mass, omental caking, and nodules in the pouch of Douglas. Due to the evaluation, a gynec-oncologist has to be involved right from the beginning of the evaluation, and the nutritional and performance data for the patient has to be assessed, and the blood parameters like serum albumin, pre-albumin, complete blood count, liver function test have to be done. Specifically for ovarian tumors, serum CA-125 has to be done, and subsequently imaging. What is the serum CA-125? CA-125 is expressed in approximately 75% of cases, principally in the serous type subtype, And it may be abundantly elevated but not reliably enough to accurately reflect intra-abdominal tumor burden. Lack of sensitivity for detecting early stage ovarian cancer, and this value may be abnormally high in many benign gynecological and non-gynecological conditions. What is the use of the serum CA-125? It helps to determine whether a pelvic mass is malignant, and in assisting in determining whether a cancer of unknown primary origin has present in the ovary, and monitoring response to ovarian cancer systemic chemotherapy, carrying out surveillance of patients treated for ovarian cancer who are in remission, and screening for ovarian cancer in high-risk population, that is, patients with a strong family history of BRCA1 or 2 mutations. Look at imaging. The first imaging modality of choice in an ultrasound, preferably in transluminal ultrasound. It shows whether the mass is solid or cystic. If cystic, whether it is simple or complex. And a complex cyst means it has thick wall, septations, which are more than 3 millimeter in thickness, solid elements, internal echogenicity, and increased vascularity on Doppler. So there is something called risk of malignancy index or RMI, which combines three pre-surgical features: serum CA-125, menopausal status, and ultrasound score. And it's a product of all these three, given with the formula Q into M into CA-125.